Myself, Dr. Jill Choksi, working as a lecturer in Physiotherapy Department at UN Mehta Institute of Cardiology and Research Center. As we previously discussed about the respiratory muscle testing, from that we learn how to evaluate and interpret the respiratory muscles. But how to train these respiratory muscles, that we are going to learn in this lecture. So today our topic is all about the respiratory muscle training. So the content of today's topic would be introduction of the respiratory muscle training, indications for the RMT, in that inspiratory muscle training and expiratory muscle training, and respiratory muscle training for the health and disease population. We'll start with the introduction. This is the technique that aims to improve the function of the respiratory muscles using specific exercise. These exercise normally aim at people for people who have asthma, bronchitis, emphysema, and the COPD. So the indication of the respiratory muscle training would be many conditions that are associated with abnormal function of the respiratory muscles. For example, weakness or increased fatigability of the respiratory muscles that is induced by the structural metabolic changes in the muscle themselves. For example, muscular dystrophy. Second one is the failure of muscle activations by the nervous system. For example, in multiple sclerosis. Third one is the functional weakness that is induced by alteration in the mechanism of the respiratory system that induce increased requirement of the muscle force output. For example, in emphysema, and the combination of all these factors, for example, in congestive heart failure. So now coming to the respiratory muscle training, it consists of two types of training, inspiratory muscle training or expiratory muscle training, or the combination of the both. So the general response to RMT includes changes in muscle fiber types, as the change from fast twitch muscle fiber to slow twitch muscle fiber, means type 2 fiber to type 1 fiber convergence, and the improvement in strength, speed, power, and endurance of the respiratory muscles. Now first one is the inspiratory muscle training. So the purpose of IMT is to improve inspiratory muscle strength and endurance, and thereby having a potentially positive effect on symptoms, exercise capacity, and health-related quality of life for people with chronic respiratory disease. There are 4 different approaches that have been used for the inspiratory muscle training. First one is the targeted resistive loading that will improve the muscle strength and endurance both. Second one is the threshold loading, will improve the muscle strength and endurance both. Third one is the normocapnic hypopnea that will improve only the muscle endurance. And the last one is the tapered flow resistive loading. This is the hybrid technique between the threshold loading and the targeted resistive loading. So first one is the targeted flow resistive loading. For generation of sufficient training resistance of at least the 30% of maximal inspiratory mouth pressure, patient has to instruct to generate high inspiratory flow while breathing through the small holes with varying diameters. If the patient is not able to generate the high inspiratory flow, sufficient training resistance of at least 30% PI max cannot be overcome by the patients. If the diameter is small, the resistance that overcome by the patients, that is larger. Because resistance that is flow dependent, device should be able to register inspiratory flow and provide feedback on the achieved flow and pressure response, that is targeted resisted breathing. Second one is the mechanical threshold loading. In this method, known and fixed resistance that is generated by spring loaded valve need to be overcome before inspiratory airflow can be generated. After overcoming this load, valve now become open and inspiration against this constant load is possible. This load should be set at least 30% of the patient's PI max, and this load is not depend on the inspiratory flow rate, whether there is a high flow rate or low flow rate, it remains constant. That is why a feedback system is not necessary in this loading method. But main disadvantage of this method is the fact that the inspiratory muscles will only receive an optimal resistance over a shorter fragment of their full contraction range. As you can see in this first graph, black denotes the pressure, green one denotes the work, and the red one denotes the volume. Initially, the pressure is too high. To reach this pressure, patient has to work harder to overcome the resistance and initiate the inspiratory volume. After overcoming this pressure or resistance, muscles cannot be able to generate sufficient contraction, and it's lead to decrease in inspiratory volume. Third one is the taper flow resistive loading. This is the loading that combines the beneficial characteristic of aforementioned training load. In this training, subject has to overcome the resistance that is not depend on the flow, whether the inspiratory flow is high or low. After overcoming this load, resistance is tapered down during inspiration. This allows the full vital capacity inspiration even at higher training resistance. This has been shown to result in higher inspiratory volume achieved during training at comparable resistance in comparison with the mechanical threshold loading. The training intensity during an inspiratory muscle training program that could be tolerated by patients were higher compared to mechanical threshold loading. As you can see in this second graph, initially the pressure is too high. So at that level, muscle has to work harder to initiate the inspiration. After overcoming this pressure, resistance is tapered down and the inspiratory volume capacity is increased. Fourth one is the normocapnic hypopnea. This type of training does not apply additional resistance to breathing that need to be overcome. In contrast, stimulating hypopnea at around 60% of subject MVV for longer duration of 30 minutes stimulate the generation of high inspiratory and expiratory flow rate. This mainly improves the endurance and not strength of the respiratory muscles. To prevent hypocapnia means reduction of carbon dioxide in the blood. To prevent hypocapnia, home training devices have been developed that allow partial rebreathing of the expired air. It is moreover challenging to perform for patients with severe expiratory flow limitations. Based on the principle of training specificity, this type of training is not expected to increase maximal pressure generating capacity. These are the basic training parameters that have to be followed. It is recommended to use either mechanical threshold loading, targeted flow resistive loading, or taper flow resistive loading to improve inspiratory muscle functions during pulmonary rehabilitation. Previously, many programs were applied that consist of 30 minutes of daily training at a resistance of at least 30% of PI max. However, shorter, high-intensity programs of 10 minutes and intensities of 40% for mechanical threshold loading or even 50% of PI max for taper flow resistive loading have been shown to be feasible and more effective. Because this shorter training duration should be well adapted to functional requirement of the patients during daily life. A normocapnic hypopnea training session of up to 30 minutes might be useful method for training endurance of inspiratory and expiratory muscles in healthy subjects or athletes. So the procedure for this training, patients with the sitting positions and wearing a nose sleeve is not mandatory. Patients are permitted to lean forward and fix their upper limbs on arm of the chair or table if desirable. It is important to stress the importance of fast and forceful inspirations and need to achieve the largest possible volume response with every breath. This will maximize the gain in the muscle power and increase total work performed during the training sessions. An initial training load should be at least 30% of patient's PI max. Because load of less than 30% PI max are not sufficient to induce improvement in inspiratory muscle strength. Symptom limited approach is recommended to guide the progression of the training load. At the end of training session, respiratory effort should be between 4 and 5 on the modified box scale. On completion of first training week, patients are often training at 40% of PI max with mechanical threshold loading or 50% with flow resistive loading. After at least 6 to 8 weeks also probably needs to be allowed to establish the effect of IMT on symptom perception during the exercise. When initiating the training, patient should receive information not only about the expected benefit and the correct technique of the training, but also about the hygienic measures that should be taken to maintain the equipment. So, second one is the expiratory muscle training. Training parameters for the expiratory muscle training, either high intensity strength training or moderate to low intensity endurance training. For endurance, EMT is 30 minutes of continuous training at 15 to 45% of the PE max. For strength training, parameter is 15 Valsalva maneuver at 60% of PE max. Both training program can be implemented using expiratory resistance at the mouth, such as threshold loading. Respiratory muscle training in healthy individuals. Diaphragm fatigue can occur during sustained high-intensity exercise. Unloading respiratory muscles can lead to increase in exercise performance. In athletes, heavy sustained respiratory muscle work has an impact on whole body exercise performance by affecting limb blood flow and limb muscle fatigue during heavy exercise. So the mechanism behind this improvement is the respiratory muscle metabolic reflex. So the respiratory muscle metabolic reflex is the mechanism to control the blood flow of the respiratory muscles during the exercise and at the rest. So as when the respiratory muscle fatigue, it activates the metabolic reflex and increase the group 3-4 phrenic efferent discharges and increase the sympathetic efferent discharge. Also it can lead to limb vasoconstriction and also decrease the O2 transport, so that increase blood flow to the respiratory muscles and decrease blood flow to the limb muscles. Heavy exercise will lead to fatigue of the inspiratory and expiratory muscles in around 70% of healthy subjects. IMT can reduce fatigability of respiratory muscles in healthy subjects. Maximal incremental tests often fail to demonstrate changes, whereas time trial or constant load tests typically improve after the training. Tasks with high ventilatory demand, for example, cycling, both inspiratory and expiratory training could be more beneficial than the inspiratory muscle training only. Respiratory muscle training in the disease population. First one is the chronic obstructive pulmonary disease. It is a condition that caused by damage to the airway and part of the lung. This will lead to inflammations. In this, respiratory muscle weakness is often observed. Adaptation of diaphragm results in greater fatigue resistance and improved muscle functions. Despite these adaptations, both functional inspiratory muscle strength and endurance remain compromised in patients with COPD and contribute to hypercapnia, dyspnea, nocturnal oxygen desaturation, and reduced walking distance. A well-controlled inspiratory muscle training for people with inspiratory muscle weakness secondary to COPD can improve inspiratory muscle function, and it can further lead to improvement in exercise capacity when added to an exercise training program, as well as decrease dyspnea and nocturnal desaturation time. Second one is the asthma. High airway resistance and hyperinflation are common features in asthma and contribute to respiratory muscle overload and increased perception of dyspnea. It has been hypothesized that IMT would improve inspiratory muscle performance, reducing asthma symptoms and therefore use of the medication. Protocol of IMT applied in subject with asthma are heterogeneous. The intervention duration range from 3 weeks to 6 months, with frequency from twice a day to 6 times per week. And training intensity should be varied from 15 to 60% of the PI max. Third one is the cystic fibrosis. IMT could minimize the consequences of impaired pulmonary function and abnormal nutritional status on the demand and capacity balance of the respiratory system. Intensity should be 20 to 80% of PI max, frequency 3 times per week to twice a day, and duration of this session lasts for 10 to 30 minutes. Beyond improvement in PI max, the systemic review revealed that an improvement in exercise tolerance, health-related quality of life, and longer respiratory muscle endurance. Fourth one is the neurological and neuromuscular disease. There are different sites of involvement. Central nervous system, peripheral nervous system, neuromuscular junctions, and muscles themselves. Such common negative consequences such as After the stroke, subject present with reduced respiratory muscle strength, reduced hemidiaphragmatic excursion of the affected side, reduced peak flow rate, and impaired voluntary and reflex cough. While in multiple sclerosis, respiratory muscle weakness is present not only in advanced stage but also in the early stage. In Parkinson's disease, PI max seems to be more affected than PE max, and both decrease with the advanced disease. In patients with amyotrophic lateral sclerosis, inspiratory muscle weakness and peak of flow decline are independent prognostic marker for the survival. Respiratory muscle weakness is progressive, leading to hypoventilations, which along with the glottis dysfunction causes an ineffective cough, mucus accumulation and recurrent pneumonia. Patients with stroke have to follow these FIT principles. For inspiratory muscle training, patients have to perform the training at 30 to 50% of PI max for 3 to 7 times per week, with each duration lasts for 30 minutes for 4 to 8 weeks. For expiratory muscle training, patient should perform the training at 30 to 50% of PE max for 5 times per week, with each session once a day, with duration of intervention 1 to 5 weeks. For multiple sclerosis patients, inspiratory muscle training perform at 30 to 60% of PI max with frequency 3 to 4 times per week, and each session consists of 3 sets of 10 to 15 repetitions for the duration of 6 to 12 weeks. For expiratory muscle training, patients should perform the training at 60% of PE max for 3 to 4 times per week, with each session duration consists of 3 sets of 10 to 15 repetitions for 6 to 12 weeks. For Parkinson's disease, inspiratory muscle training perform at 15% of PI max, progression of 5 to 10% at each session up to 60%. Frequency should be 6 times per week, with each session duration is 30 minutes. So the overall duration of the intervention is 12 weeks. For combined inspiratory muscle training and expiratory muscle training, patient should perform the maneuver at 50% of PI max and PE max with frequency 6 times per week. For total duration of intervention is 2 months. For amyotrophic lateral sclerosis, inspiratory muscle training perform at 30 to 40% of PI max with frequency 5 days per week, and duration of each session consists of 10 minutes with twice daily. And the overall duration of this training is 8 weeks. For expiratory muscle training, patient should perform the training at 50% of PE max with frequency 5 days per week, with duration of session 5 sets of 5 repetitions, and overall duration of intervention is 8 weeks. Fifth one is the chronic heart failure. Impairment of cardiac function is the principal factor associated with reduced functional capacity in people with chronic heart failure. Abnormal respiratory muscle functions play an important role in premature exercise termination and contribute to sensory consequences, especially breathlessness on exertions. Ventilatory muscles are subjected to increased work of breathing, which may lead to respiratory muscle fatigue. As a positive consequences of high work of breathing in people with heart failure, however, diaphragm exhibit a predominance of slow myosin heavy chain isoforms A, with an increase in oxidative enzymes and decrease in glycolytic capacity. With the use of threshold inspiratory muscle trainer, inspiratory muscle training perform at 30% of PI max or 60% of PI max for the frequency of 7 days per week, with each session duration consists of 30 minutes, and the overall duration of intervention is 12 weeks. Inspiratory muscle training for people who have a chronic heart failure increase inspiratory strength and endurance, increase maximal exercise capacity that is reflected by improved exercise duration or oxygen consumption. IMT can be considered as an additional tool that is safe and effective in comprehensive management of respiratory muscle dysfunction in patients with chronic heart failure. Sixth one is the weaning failure. A spontaneous breathing trial can be used to assess readiness for extubation with the performance of serial measures such as tidal volume, respiratory rate, maximal inspiratory airway pressure, and the rapid shallow breathing index. Peak cuff flow is the useful parameter to predict the successful weaning in patients with neuromuscular disorder or spinal cord injury when extubation is anticipated. The inability to breathe spontaneously relates to an imbalance between the load on the respiratory muscles and the capacity of respiratory muscles. Daily inspiratory muscle training with 6 to 8 contractions repeated in 3 to 4 series at a moderate to high intensity was safe and improved both inspiratory muscle strength and weaning success in patients with difficulty weaning. These are the reference for this topic, Alan Hilges and Donna. Thank you.